Okay, I have the pleasure of introducing the next speakers. So Neil Francor and Mark Buchner are co-founders of the tech startup Tactum, which is an evolving platform supporting modern web-based clinical content, guidelines, decision support, and more recently AI and ML. Also presenting is Erik van Eaton, who's an award-winning surgeon informatics that works with health systems all over the world and collaborates with Tactum team to help implement their platform in health systems. So they're going to be discussing their work as a success story in public-private partnerships.
Thank you. I thought my job was to be introducing these two. I guess maybe we're a panel. Awesome. It's a panel. Welcome. Great. So my name is Erik van Eaton. I'm a trauma surgeon at Harborview Medical Center, and I failed to put in my disclosures. I actually am a co-founder of a health IT software company called Transformative Med, which has nothing to do with what I'm going to talk about today. What I'm going to talk about today is entirely within my role at the University of Washington. And that is off, and that button doesn't do anything. This one? So there I was, general surgery intern. And I have a patient with a pelvic fracture and a small stable subarachnoid hemorrhage. And I want to know, how do I do VTE prophylaxis? And up-to-date is helpful. But remember, the up-to-date guidelines said stable hemoglobin. What does that mean? Is that 2 hemoglobins 6 hours apart, 6 hemoglobins 2 hours apart? How do we do it here? The other questions that I had were related to projects that were ongoing at the University of Washington. So we were actually accumulating evidence about blunt cerebrovascular injury. And for a while, if you had a bruise, a seatbelt bruise across your neck, that would be an indication for a CTA. And then we found out maybe that wasn't actually really an indication. So things were changing within our organization. And then I had this question about, now I've got a stable trauma patient who is 38 weeks pregnant, and this is a high-risk pregnancy right now because of her trauma. We don't have a high-risk L&D unit at Harborview. Our high-risk L&D unit is down the street at the Montlake campus. What do I do? Whose job is it to hand off which part of this patient to who, right? So the trauma chief is supposed to call the general surgery chief, but which parts are handed off by them and which OB talks to which? Where is this written down for me? So I got together with our medical librarian, Amy Harper, and actually in 2004 said, can we have a website where we just put all this in one place for people like me? And by the time 2011 rolled around, we said, let's figure this out. So we found 33 clinical websites at UW, 14 of which were open to the World Wide Web, 19 were password protected. 11 of those would block you if you weren't in the correct department within UW. We sampled 22 of those websites. We found 382 protocols and guidelines, 276 broken links. 10 sites out of the 33 contained information about the date, how old was this content, where it got its sources from, and who wrote it. None of them said that there was any kind of peer review or verification process behind it or an approver. And of course, none of the content was visually standardized. So then we went around and said, well, what are people looking for? So that's what's available. That's a hot mess. What are people actually looking for? So in the clinic and on rounds, we found that our providers were actually looking in reference systems when they were making patient plans. On rounds, they were heavily using mobile devices because they were on the move. They were asking Dr. Google, that unassailable bastion of scientific knowledge. Some of them were looking up PubMed, and then they're like, well, I found an RCT, but what do we actually do here? UpToDate was heavily used, and there was another application called Dynamed that was heavily used because those were more consumable at the bedside. Our 2011 pilot study walked around on rounds in the ICU for 23 days. and we found 38 clinical questions that came up. 40% of them were actually related to internal institutional protocols, not national guidelines, but how do we do it here questions. And the attitudes towards those guidelines were favorable. People wanted to look up guidelines, but the answers were hard to find. Their information seeking behavior involved the smartphones, like I mentioned before, but also back in those days, we had these little pocket cards that the pharmacist would hand out. Okay, everybody, like here's the first line of therapy for presumed ventilator-associated pneumonia. And then once you actually found some evidence, it wasn't really actionable when clinical decisions were being made. So there were information and knowledge gaps. So here's our intervention. The first thing that we had to do was form an editorial board to accomplish harmonization and standardization. And this has to do with the content itself, nothing to do with how it's delivered, where it's stored, what ways that you access it, but what is the content itself going to look like? What are going to be the rules for a piece of content that our system will have? And the second part was the delivery system. How will you get to it? Will you get to it on a smartphone? Will you get to it on a desktop? Both? And we discovered that, or decided in some cases, that the content had to be easy to find. So it had to be in both places, on a smartphone app that could come up whether you had an internet connection or not. And it had to be available on the desktop, because sometimes you're answering questions at the bedside without a computer, and sometimes you're answering questions while you're writing orders and you want to open it up on your workstation. It had to be clinically actionable. So in other words, consider A or B or C. A lot of our guidelines said, order this order set. And then inside the order set, there might be some options or choices. Or we would say, if your patient meets any of these criteria, order a CTA of the neck. And it had to be served intelligently. And that's what Mark and Neil are going to talk about. A robust IT platform that allowed updating, non-interruptive content refresh, security protocols, and all of that. So easy to find. It's an app on my phone. Anybody wants to see it, I can show you later. Nice, big, tappable areas. When you're in the trauma bay, there's no mistaking what you're trying to look up. It's also searchable with very intelligent search algorithms. Clinically actionable, get a CTA if your patient meets any of these criteria. There's additional information you can keep reading about, well, maybe in some if other conditions are also met. But for the upfront design, it's like, you got to say, in this case, do this thing. And it needs to be served intelligently. So I mentioned this before. It used our own organization's security methodology. And that was important because we could extend those security credentials from the University of Washington, not our EHR credentials, but our academic credentials, we could extend by making people adjunct faculty. So people in rural hospitals, if they wanted to, they could become adjunct faculty, be given a UW-Net ID, and access this content. All of the content is securely stored in the cloud. And so through a business associate agreement, it is actually covered by our security arrangements. And so when our lawyers say, don't you dare share that CTA algorithm with the rest of the world because that could expose us to liability, we say, don't worry, it is password protected and it's secure in the cloud. And then the most important thing that we did was require author and approver metadata and a non-interruptive process. So we include not only the reference material that you can dive into if you want to. It doesn't interrupt you when you're trying to figure out what to do in the moment. But if you want to go down to the bottom of the piece of content and read, like, who made this? Who wrote it? Who approved it? Who allowed this to get posted at my hospital? And how old is it? So somebody in my group, some of you may remember me as a loudmouth of the blue VIP group, but somebody asked about, like, what are we going to do about keeping the content current? So in our system, we don't stress about how current it is. We just tell you, when was this last updated? It's up to you as the clinician to decide whether that's too old or not. And I will tell you, like, antibiotics for open fracture, that content's from 2014. And I was dead set against having content expire and be unavailable at a certain date, because refreshing the content should be a clinical process where you look at your outcomes and say, these are great outcomes with 2014 data. That one can stay unchanged. But this one, CTA for the neck, we've got new information now. We're updating it this year. And so we just tell you how old it is. Okay. There's our non-interruptive updates. So you can actually skip the update, which actually does take a few seconds to push out updated content. You can skip it if you're super busy, but it will keep reminding you every time that there's an update in here. And a lot of these things, the metadata availability, the cleverness of the updates, how you do this, it's all based on the platform. And the platform is so flexible and so smart that we started getting other organizations or groups within our organization coming to us. So our aeromedical transport provider came and said, because your content is available offline, can we use that platform? Here are these paper notebooks that our airlift nurses carry with them on the aircraft. Can we put this on that platform? The operating room came to us and said, all of our circulating nurses are looking in different places for their find lists. You know, when the surgeon asks for a specific tool or something like that, there's a locating system in the operating room where they go and find it. And they put that information on this platform. Our administrators on call put all of their administrative policies and procedures on this platform. So again, the platform technology is one question that this group needs to think about. And then the content methodology is a separate question that can be agnostic of the platform. And who does the content apply to? How do you make it? How do you set rules for what the content looks like so that you can include the patient's voice, the administrator's voice, the EMR transport voice, the surgeon's voice, the nurse's voice? Like all of that stuff can be in your rules for what the content looks like. And then you need to have a smart platform. And to tell you about the smart platform, I am going to hand things off now. Mark Buchner.
Wish you hadn't used the term smart 3 or 4 times there. We've got a lot to live up to now. We've got 227 slides to take you through, so you're all here until about 9 o'clock tonight. I'll go through them quite quickly, and I'll speak as slowly as I can so you can understand my strange Scottish accent. Occam's been used, and there's a couple of other strange terms, Latin derivatives. Occam is the implementation of the Tactum product, Curus. So Tactum is the company and Curus is the product. We've got 2 flavors of product. So it's a single platform. One is directed at supporting clinicians and the other at patients. And I'll talk a little bit about well, we're going to focus today on the clinical companion. And Neil's going to talk a little bit about the ecosystem later. There's a range of other things that we do beyond Curus, but I'll not bore you with that today. Seem to have fallen foul of the same. So knowledge into action, evidence into practice. Essentially, the focus of the Curus Companion is to take clinical guidelines, principally, but not just clinical guidelines, can include other resources, decision support tools, protocols, policies, and make them actionable at point of care or at the bedside. That's the focus of the Curus Clinical Companion. I would say, well, Erik's already touched upon it. One of the kind of key drivers for the work that we did with Clinical Companion was to ensure that it's available through multiple channels: web, the EMR, mobile device, tablet, online and offline. And I'll talk about measurable later. The learning health system has been used in quite a few slides over the last few days. And again, that's relevant to the work we've been doing. On Q, learning health system. I'll not talk about this. I think most people in this room probably understand what it means, but essentially, one of the kind of backdrops or the kind of key considerations to designing the platform was to ensure that we've got a means to take data and feed that back to support clinical practice, improvement, development, guideline development, improvement. And in yesterday's slides, there was talk about different levels of decisions for L1 through L4 and L5 in terms of AI. I think it's possible to support elements of the kind of concept of learning health system across all of those spectrums. So even though you don't have a particularly computable or heavily kind of IT-based technology, it's still possible to support elements of the learning health system. I'll talk a little bit about that later on. So that decision support spectrum I mentioned, L1 through L4, that came up in a few slides yesterday. I suppose this is really just another kind of view or perspective on that, where on the left, you might consider those kind of decision support resources L1. They might be narrative-based, they might be guidelines, as you're likely to find them these days. And as you move across the, oh, yikes. As you move across the spectrum from left to right, the decision support capabilities evolve. So clinical calculators, scoring tools, risk stratification tools, that's another form of decision support. And when you start to embed or integrate that with patient data, that takes it further along that spectrum. And then at the far end, you've got AI and automation. So with this kind of concept in mind, we've developed the Curious platform to support elements across all of that. It's not quite a simple linear kind of pathway from good to bad or kind of poor to high quality. All of these tools can be integrated and used together to do different things. So for example, we're using AI to support the improvement and the creation of clinical guidelines. We're using or embedding calculators, scoring tools within clinical guidelines to make them more actionable. So these things aren't quite as delineated or segregated as are presented in this slide. I won't say too much about this. It's kind of geeky talk. There's a lot of technologies, there's a lot of standards, a lot of guidance and tools and resources to be used to support the implementation of CPGs and other decision support resources and tools. There was a lot spoken about yesterday, HL7, CPG on Fire, very important. And again, thinking about what we've done with Curious, we've tried to adopt and support as much of this as we can. One of the key challenges in taking decision support or clinical guidelines from that left-hand side of the spectrum to the right, making them more computable, moving from narrative-based to computable-based or knowledge-based to driven, is that it requires time, effort, and resource, which is precious. And so this is really just to point out that that is one of the challenges. I think the positive note here, though, is that there's a lot that can be done across that entire spectrum of decision support or capabilities, clinical guidelines in digital form, moving them to a more structured, computable form. This is all possible. I think in thinking about some of the presentations I've seen over the last few days and listening to the sessions that we've had, I think a roadmap is a key development part of this program to take you from where you are now to where you want to be in 3, 5, 10 years' time. And with that, I think I'll hand over to Neil. Thank you.
So, pretty much all the benefits have been really nicely covered here by Erik, and so I'm not going to spend too much time here. I'm going to move on to the principles that I really wanted, the message that I wanted to share in regards to kind of how we're going to end this talk. But one is standardization. So one of the first steps that we did when we were putting together Occam and the setup over at the UW was to put all of the content into the system. And the first step was just to take whatever came, and it came from all those various sites that Erik mentioned. And it was in PDFs and all sorts of different forms. And we did our very best to put together a template. And the template came from, it's a group called Agree2, which is Appraisal of Guidelines Research and Evaluation Group. And so that kind of came to a place where we wanted to get to. And now that the program's been running for about 6, 7 years, we're getting closer and closer where the template gets more and more used each time an iteration gets done. So we provide that to the content authors and collaborators and the approvers, and they start plugging it in. And so it gets used better each iteration. So, but we were happy to take whatever we got when it was originally set up. So again, it's a journey, and the iteration just kind of carried on. Then the next one I wanted to share was collaboration. Now, this is an international project that was based with a group in the UK. They're called the Commonwealth Pharmacy Association, and they had a whole bunch of content and an imperative to make antimicrobial stewardship available in 26 African nations. So some of the African nations had really good content. Some of them had no content, and everybody was sort of interested in following the WHO. So basically, we set up the platform, and so that each of those countries had a section within the app. This is all open content, so each one of them can look at each other's. Where they had content, we uploaded that. We have an overlay where everybody can easily just touch a button and it brings you to the WHO content. And where they didn't have any content, they came back and they developed content. And they might have used, you know, neighboring countries or built it on their own, and they came up with their set of content. So that site is available for you guys to even take a look at now. And so there's our example of kind of collaboration. And then lastly, sharing. This is we also do a very similar type project that's like Occam with the University of Michigan. But in that program, they're really open within the trauma program and surgery to have their content open to the public. So they kept asking us, we want it to be in front of the firewall. But unfortunately, the organization was unwilling to do that because there's a lot of content that's just not theirs. So we came up with an agreement where the content that they were willing to put in front of the firewall would be open source. And so again, the previous talk, Creative Commons, this is all Creative Commons licensed content. We put it, opened up a site called the Ecosystem, and all of their content is now available for anybody to use. And so it actually sat for quite a while where it wasn't getting used that heavily. But just a couple months ago, we got this really nice email from Dr. Raghunathan, if I'm saying his name correctly, who is in India, and you could absolutely see the statistics in the back end of the site where it's getting quite a bit heavier usage now. And any time that we have anybody's content that they want to make available on the ecosystem, you know, please reach out and let us know. Just to kind of to close up, I'll just show you a few slides. This is kind of what it looks like in regards to the mobile app. This first slide is some guidelines and what they look like in various organizations. Here's some, well, there's a formulary here. The next ones, I got some calculators. We've got a few drug calculators that say Airlift uses. We got PALS calculators as well. And some algorithms. The algorithms, it works really quite nicely. One of the nice things about it is that you're unlimited for content. You can, you know, with a PDF, you're pinching and zooming. Right here, you can just kind of put this endless amount of content in each one of those boxes. And then here's some clients that we're working with. And at that, I'm gonna just close up. Any questions?
We do have time for some questions. So it seems like this is something that you interact with specifically in your app, but is there like an option to connect it to like an EHR so that you could pull in patient specific content in a secure way and be able to get personalized recommendations using the content that you have?
So
Short answer is yes, but yes is always the answer with technology. Never easy though. Yes, so using HL7 info buttons is one way, CDS hooks, so those are the technology capabilities. The platform will out the box kind of connect in those ways. The challenge in my experience has always been getting engagement with the vendors to facilitate that interaction between the AMR system and the decision support. Because is anybody here from Cerner or Epic? Nope. So
I'm familiar with that challenge though, so.
right, okay. So does that answer your questions?
Yeah, I was just wondering if you currently did it, because I wasn't sure by how you presented it, if that is a way that content can be,
Yeah.
like I said, personalized. So there could be something from your app that connects to the EHR, again, authenticated, whatever, and then securely brings in the patient data, interacts with, and it would have to use standards or something like that in order to give the personalized recommendation. Is, I mean, to your point earlier, you want to be able to treat, in a lot of cases, the specific patient that's in front of you. And so that would actually quicken that. You wouldn't have to think through. It's almost like a cognitive support.
Yeah.
You wouldn't have to think through, what do you do in this situation? If you have X, Y, Z, A, B, C, you kind of get that answer quicker. So I was just curious if that was something you've already built into your platform. It sounds like the answer is yes, with some challenges in actually doing that integration.
Yeah, 100%. I think another thing to think about there is that where is point of care or at the bedside, it's often not with a computer in front of you. So our kind of key or our focus initially was certainly making sure that this content, the resources were available essentially on a mobile device in your pocket at any time.
I think the punchline for this meeting is that both have to be available, right? So you wouldn't want to have two separate systems, one that's integrated in the EHR and another one that's available on my smartphone. You want to have one system running in the background that can serve the content in all of those ways.
More questions? I think my key observation from the last few days is that I think the approach that's being taken is absolutely spot on. It's a user-centered design, it's agile, it's iterative. Technology is almost certainly not going to be your problem. The problems are going to be people, institutions, organizations, and all those other more challenging things. So good luck.
I second that observation. So I lived this life, for more than a decade in a microcosm in our health system. And that's exactly what we discovered is there's lots of technological options to accomplish the deliverable goal, the delivery goals. The question is creating the content. What does the content look like? What are the rules going to be that say that this content is postable? We called our content, we called them advisories because there was even argument about, like, are these protocols, are they algorithms, are they guidelines? What happens if we call it a guideline and somebody doesn't follow it? So we're like, these are advisories, and they look like all kinds of things. There's flow charts, there's PDFs that you read through, there's pictograms, there's tons of different things. And I think the key is, just like the agile process recommends, is start with something. Don't try to start with the end product. Start with first step and iterate from there.